Hello, I'm Dr. Emily Peckham. I'm a research fellow in the Mental Health and Addictions Research Group at the University of York. So the benefits of stopping smoking for someone with severe mental illness are the same as for anyone else. I think there's still some false beliefs that smoking improves people's mental health, and there's the belief that, they're not feeling very well at the moment. Perhaps if we take away their cigarettes, that might make them feel worse. They've not got anything else in their life. Whereas in fact, if somebody does stop smoking, there is perceived to be a deterioration in their mental health. That's often because of the effects of nicotine withdrawal. When somebody's withdrawing from nicotine, they will experience anxiety and they will experience those kind of symptoms. And those symptoms are not to do with a deterioration in people's mental health. They're just to do with the effects of nicotine withdrawal. When we first embarked on the Scimitar programme of work and we were looking at helping people to stop smoking, people were saying to us, why do you want to do that? Why are you taking away the people's cigarettes? And we've seen a real shift in attitudes in mental health services over the course of the last 10 years that we've been doing this Scimitar programme of work. The fact that so many mental health trusts engaged with the Scimitar study, and 20 mental health trusts took part and helped us to recruit the participants to the study. And I think that shows how things have changed over time, where people before would be a little bit reluctant to take part in such a study. One of the biggest issues really is lack of resource. So that could be lack of resource in terms of time. And when people within community mental health settings are already stretched, anything that takes any additional time just falls to the bottom. There's also a lack of resource in terms of financial resource. So a lack of money to provide that, the intervention. So to employ enough people to deliver an intervention. There's also a lack of skills. People don't always have the skills or have had the training in terms of what to do and how to help someone to quit smoking. So at the present, the system's very confusing. It's very difficult for people to know where to go. And clinicians themselves don't know where to signpost people to get that help. Really, having a clear system and clear pathways that both primary care and community mental health settings know about, and so they can work together, and deciding who is going to provide that service, who's going to provide the stop smoking service, and where do people need to go to access it? What's the point of contact? So if somebody was approached by someone within a community mental health setting and they spoke to the person about their smoking, then where do they signpost that person to go to? We found it was very difficult for people to access nicotine replacement therapy, which is a standard stop smoking medication. In some areas, GPs have been told not to prescribe stop smoking medication anymore. So then where does the person go to access that medication? It became all very difficult. And that's, any of those hurdles, when somebody wants to do something about their smoking, those need to be removed so that person, when they've got the motivation to quit, then they're able to quit and do something about it at that time point. We've conducted two studies. We've conducted the Scimitar study and Scimitar Plus study. The Scimitar study was a pilot study and that had 97 people in it. And then we went on to conduct the Scimitar Plus study, which was exactly the same as the Scimitar study, but it was a full-scale study and that had 526 people in it. The results of the main study, the Scimitar Plus study, were that people who received the bespoke smoking cessation intervention were twice as likely to quit smoking as those who received standard stop smoking services. So the difference between our bespoke smoking cessation intervention and standard stop services were that the intervention was delivered by a mental health professional. And people who we spoke to about the service and the service that we provided, the bespoke service, said that they really valued the fact that it was provided by somebody who understood their mental health. So we found that people were a bit unconfident about making an abrupt quit sometimes. Not everybody, and the best way to stop smoking, of course, is to make an abrupt quit. But for some people who didn't feel able to do that, we offered them the opportunity to do a structured cut down to quit. So that's where they looked at how many cigarettes they smoked per day and then cut out a set number of cigarettes per day. And then with the hope that they would then go on to be able to make a full quit attempt. Once they'd gained the confidence that they were actually able to cut out some cigarettes per day, that they would be able to make a full quit attempt. So we offered people that opportunity as well. The intervention was also less structured than standard smoking services, which generally consist of 4 meetings with a smoking cessation advisor. People in our intervention could have up to 12 meetings with the advisor, and they could have 1 or 2 meetings before setting a quit date, or more if needed, so that their needs were really met and they could really talk about what they were going to do in place of smoking and come up with some clear strategies about what they would do. Because one of the reasons when we asked people about why they smoked was boredom. And that was quite different to people who without severe mental illness, when they were spoken to about why they smoked. Boredom didn't come up as such a factor, but that was a real factor. Nearly 90% of people said they smoked because they were bored. We also had a flexibility over venue. So if people wanted to be seen in their own home, a place where they felt really confident and comfortable, then the smoking cessation advisor would go to them. Because we found that people are much more likely to be successful if they're able to have the intervention somewhere where they're confident. Because of course people can feel quite nervous about making that change, stopping smoking. So feeling as comfortable as possible about doing that was important to people. And what we hope really is that people would be able to access a Scimitar style intervention within mental health settings. So an intervention delivered, within community mental health teams or within a community, within an NHS mental health trust that met their needs. So it was delivered by somebody who understood mental health and understood the challenges that people faced. And I guess that's our hope really for the future.